Right, here we go. Ultrasound guided cannulation, under 30 minutes. I'm Sean, I'm an anaesthetic trainee in Darren Valley, and I'm helped by George. And this is the third year of doing this course, and hopefully we get in there in 30 minutes. Start to finish, novice to ready to go and do some supervised practice. Why? In my opinion, everyone can learn this skill, and I think it's a fantastic skill and it's good for patients. We've all been in that situation. It's 5 o'clock, the patient has not had any antibiotics or has been waiting for their contrast scan for the past 3 days, and you have to beg the anesthetic reg to come with their ultrasound. It should be a thing of the past. There's loads of ultrasound machines now, and everyone can learn this. Honestly, you can learn this. And so the thought is that we're going to do this 30-minute lecture, and then you come out of it and you're able to come to do our procedural courses where you practice your needling. And this is going to give you the skills and the knowledge to call up someone to come and supervise you on the ward to do some supervised practice. So our aims are 30 minutes. You're going to know the basic ultrasound function and buttons. You're going to know when you can and can't do ultrasound guided cannulation, what some of the risks are, and how do you do safe technique with particular attention to infection control, anatomy, and needling. Some things that we're not going to cover. Last year we did a similar lecture. It was too long. Nothing on evidence, nothing on IOs, cannula flow rates, how to give fluids quickly, and assessment of fluid responsiveness, and how you can improve your cannulation. These are all things that you should go away and look at before you go to ultrasound cannulation, in my opinion. But here we are. So knowledge check. You can pause it here and try and answer some of these questions. You're going to be able to answer all of these by the end of the course. Why should you learn ultrasound? In my opinion, in 5 to 10 years, everyone coming out of medical school is going to be confident, competent with ultrasound. It is now becoming an essential part of clinical examination. You can assess anything from A to E, reversible causes in ALS. You can find the cricothyroid membrane. You can pick up pneumothoraxes and consolidation with a higher sensitivity and specificity than X-ray and examination combined. Tests of actual fluid responsiveness or tolerance, like the VEXA scan, raised intracranial pressure, PEs, DVTs, lines, the whole lot. And it's now part of the EM and acute internal medicine curriculum. If you want to learn more about POCUS, there's a book that comes out every single week, but you can learn loads online through Twitter, YouTube. There's lots of apps. So what is ultrasound? Let's talk about some of the basics. So ultrasound is sound waves which are high enough frequency that we can't hear them. They're by definition above 20,000 hertz, 20 kilohertz. Bats can hear them. That's how the echolocate submarines use this for sonar. And it's essentially electricity that makes a crystal called a piezoelectric crystal make sound waves. The sound waves go down, they get reflected, they come back up, and they get turned back into electricity, and the computer interprets that as an image, and it can tell you things like distance, density, and direction of movement. For our purposes, it's important to know that the beam that comes out, although it might be wide, is extremely thin. It's almost as thin as a credit card. And I think of that as a 2D section. Like if you've got a samurai sword and you chop through someone's arm, that's what you get. So here's someone's lumbosacral spine, and it's been chopped through as a sagittal section, and this is the corresponding ultrasound image. You can use ultrasound to determine the level, or the true level. We're not very good at it by landmark for doing lumbar punctures and spinals, etc. So here we go, superficial to deep, and the different colors correspond to how strongly something reflects sound waves. So things like bone that reflect strongly, they're white. So here's some spinous processes and vertebral bodies. And things that don't reflect are air and fluid. This is actually an epidural hematoma. That's why there's a black strip there. And also important to point out that sound waves, they don't penetrate the bone. So behind the bone is just black. And that's not because there's something there which isn't reflecting. It's because there's no sound waves going through. So black is fluid, air, and shadow. When would you use it? If a patient's difficult. And here's a list of patients that I've used it on. Contraindications, the usual sort of stuff. But also you're going to be going for deeper veins, and we'll talk about it later, but there's a deep vein here called the basilic vein, and they might be saving that in the patient with end-stage renal disease for a fistula. So just be mindful if someone's got renal failure, speak to the nephrologist. And also if they're going to need this access for a long period of time, or they've got very, very deep veins and this cannula is likely to tissue, maybe a cannula is not the best bet, and what they actually need is a PICC or a midline. Risks, well, the main risk is extravasation. We'll cover these later. Also, if you're going for deeper veins, then you might hit a nerve or an artery. So what are some of the basics? I think of it in 5 phases. The first phase, which is probably the longest one, is gathering all the equipment, finding the ultrasound, getting a load of equipment. If you want somebody to come and supervise you, I think this is probably the best bet, is if you get all of that stuff and then call them. Next step, you go to the patient, you set the patient up and the machine. Then you're going to do a quick scout, which is non-sterile, and you're just looking for a nice vein. Optimize your image, maybe leave a mark, either with some local little blood prick or putting a needle hubcap, making an indentation like you would do for pleurocentesis or a lumbar puncture. Then you're going to clean the patient, put a probe cover on, and do the business. One of the most important things, and that you will probably be doing some sort of version of the right, is ergonomics. So what you want is your needle, the screen, the probe, and the target all in a straight line, so that you're just able to look up and down, no turning, no stretching. And you want to be sat down with your arms resting on the patient. Just imagine if you're playing snooker, you wouldn't be playing with your hand and your snooker cue up in the middle of the air. You have them low down, rested, nice and secure, so that you're steady. And also important to pay attention to the patient's ergonomics. If you're going to go for the basilic vein, it's very difficult to maintain external rotation and abduction of your shoulder for more than a couple of minutes. So if you pile a load of pillows underneath, and I think a good way to do this is with either their bedside table or a procedure trolley, loads of pillows and Inco pads, make it more comfortable for them. Setting up the machine, there's 4 things you need to think about. The first one you pick up is making sure that you've got the right probe selected. If you pick up one of the probes and it's not selected on the screen, then it's going to not generate an image. You need to choose the correct probe, and we'll talk about that in a sec. Then you need to check if it's orientated correctly. So on the screen, you can see somebody's tapping the left side of the probe, and hopefully the left side of the screen flickers. But if the right side of the screen flickers, then you need to turn the probe over. Then you're going to adjust your depth and your gain. So you can see on the right side of the screen, remember this is superficial deep, it goes all the way down to 4 centimeters, and you've got depth marking. So this is about 2 centimeters. You can adjust the depth on your machine. So you could have it all the way down to 10 centimeters. But if your target is in the first 1 centimeter, that's 9 centimeters of wasted space. Your target is going to be very small. If you reduce the depth to 2 centimeters, suddenly your target's very big, and you want your target to be in the middle of the screen and nice and big. And then adjust your gain. So here's low gain, high gain, and just right gain. And you can see here that it's much easier to tell the tissue planes apart if you've got your gain correct. So where are these buttons? You might look at an ultrasound machine and be intimidated. There's so many different buttons, but just be reassured there's only really 3 that you need. Here's gain, here's depth, and here's setup. That's where you can change your probe. All these other buttons are things for saving images, manipulating images. You can freeze, you can measure things like AAAs. You don't need them. And here are some different modes. Most of the time we're in 2D mode in this orange box, but there are some other modes in green, which we'll talk about later, which can be helpful. There are 3 probes on most machines. Some machines only come with 1, and they are named according to their shape and what you use them for, their frequency. So the one that we're going to be using is the linear probe, called so because the face is linear and the beams come out parallel, and it makes like a linear shape like this. Whereas the curvilinear probe is curved, the beam comes out like that, it's curved. And you would use this one for superficial structures because it's high frequency, therefore it's high resolution, but it doesn't penetrate that deep. So it's things like thyroid, nerves, vessels, whereas the curvilinear probe or the abdominal probe is for deeper structures. So you might use that in a fast scan or looking for a AAA. The last probe to talk about is echo probe or the phased array probe. It's low frequency and it's shaped with a small face like that so that it can fit in between the rib spaces. Perhaps the most important slide, and where I see most people doing ultrasound guided cannulation wrong, is sterility. So you absolutely can't use the gel that comes with the ultrasound machine because there have been swabs and it's grown all sorts of nasty anaerobic coliforms and all sorts. So you can't use this. You have to use the sterile single-use lube packets, but you don't have to use gel. You can just use a PosiFlush saline, and it's maybe easier. Your probe doesn't slip all over the place. It is fine to introduce some of this gel into the intravascular space. You definitely have to use a probe cover. I know of a patient that got hepatitis from a dirty probe, but apparently the tegaderms, they ruin the probe, so you should use something else. At Darent Valley, the SOP says that you have to use the central line sheath, this big one. I have previously been using something like this, which is a sterile glove, which is fashioned into an ultrasound probe cover. You can watch a video of how to do that on this website here, which is Academic Life in Emergency Medicine. Great website. In terms of skin preparation, in the SOP that we say that you have to use the 2% chlorhexidine lollipops. Remember, you might be scanning this big area here, so you're going to have to clean a large area. You can't just use one little swab. You have to clean a large area. Just check that your patient's not allergic to chlorhexidine. And there's a study that compared the 0.5%, which is what we use for things like spinals and lumbar punctures, versus the 2%, and there was no difference. But our SOP is that you use these. Remember that peripheral venous cannulation is an aseptic technique, so non-sterile gloves, sterile lube, and a probe cover. And I use a wound care pack, so you've got a nice sterile place to put your probe once you've cleaned it. So how do you hold your probe? You'll start off holding it like this, and you'll be sliding all over the place. You want to hold it nice and low down and rest your hand on the patient. And know that there are 10 different moves that you can do theoretically with a probe, and you want to do one at a time so that you don't get lost. So you can do, they call it PARTS, the acronym. So pressure, angulation, rotation, tilt, and sliding. So you want to do one at a time. If you do a combination of 3, you're going to get lost a lot easier. And also try and make your moves really, really small when you start off, because you will get lost. Okay, now to talk about M mode, which is one of these different modes. So M mode, what is it? M mode is helpful to us because when you push it once, you get a midline marker. So when you push it once, you'll get this like gray line come up, and you can move it left or right using your trackpad, but by default, it comes up right in the middle of the screen. And that corresponds to right in the middle of the probe where that arrow is. So you know that if you put your needle underneath the arrow, it's going to turn up where that line is. And that's helpful. But when you press it twice, you get a different view. This is what M mode actually is. And so M mode is looking at one crystal. Imagine this is an array of crystals. It's just looking at this one crystal, this one here, this line, over time. And this is actually somebody's chest. So here's 2 ribs and pleura, and this is how you pick up pneumothoraces with ultrasound. You use M mode. But if you get into this, push the M mode button again, and then you'll exit it. So let's look at some examples of ultrasound now. Here's ocular ultrasound. Remember, we said it's a 2D section, superficial to deep. Here you've got anterior chamber, posterior chamber. You can pick up things like retinal detachments. Here's a carotid sheath, so somebody's neck, and you put the probe on, and you can see IJ and carotid, and that's probably the first ultrasound-guided cannula that we do as anesthetic trainees, the central line. It's probably a bit easier than something like this, which is the upper arm. Remember, we spoke about the basilic vein earlier. Look how big that is in comparison to the brachial artery. And you can't see this. So in my opinion, it's the best one to go for. It's the first one that I'll go to, the first one that vascular access nurses go to. But look at the proximity to some of these important structures. So you've got median nerve right next to it, and not too far away, you've also got brachial artery. So until you're skilled at doing your needling, you want to stay well away from the ACF and only practice in the forearm. And also important to point out, sometimes all you can see, you don't always have the basilic vein. All you can see is the brachial artery and 2 brachial veins. You definitely don't want to go anywhere near this area until you're very, very, very good. But the forearm isn't without its risks. Remember that anatomy-wise, the distal wrist, the radial artery, is superficial, but as it comes into the mid forearm, it dives and it's going to be deep. So just because you put the probe in the middle of the forearm and you see something round and it's not superficial, don't be fooled into thinking that's a vein, because it might be the radial artery. We'll talk about next how you can differentiate arteries from veins. Just be mindful that it could be the radial artery. I also like this to point out that look here at the wrist. Look how superficial the radial artery is. Like it's literally 3 to 5 millimeters deep. So this is good for teaching people when they're doing ABGs, as I used to struggle. If you've missed and you've put the needle in, you've probably it's not going to be deeper. You don't need to go deeper. That's often not the issue unless you've got somebody with very, very thick wrists. And also to the left and right of the radial artery is often two little veins. And so if you put your ABG needle in and you're aspirating, you might hit one of those and you get that's when you get the venous gas, or your mixed gas. So yeah, practice in the mid forearm. Don't go anywhere near the ACF. Pick somebody like me. Don't pick the 90-year-old who's 150 kilos and they've got dementia and they're edematous. You want to pick an easy patient that's going to let you have a look. Although there will be superficial veins, use the ultrasound, use the mid forearm and look for some deeper veins and practice that way. So how can you tell the difference between an artery and a vein? We all know this. Arteries are rounder, they are non-compressible, and they're pulsatile. Whereas veins are thin-walled, oval, and they're usually non-pulsatile and compressible. I say usually because there are some situations where you might have a compressible artery. So if they're hypotensive or it's a small peripheral artery, you'll be able to compress it. Remember, the brachial artery, the pressure is like 140 millimeters of mercury. You can compress it if you push really hard. Also important to point out that you won't see an artery pulsating unless you put some pressure. So just like when you feel your own pulse, if you just put your fingers over your radial pulse, you won't feel it. You have to push a little bit harder to feel the pulse. And then if you push really, really, really hard, you can occlude it, you won't feel a pulse. Sometimes you'll get a vein which you cannot compress, for example, if it's got a clot in it, or you could get a pulsatile vein if they've got a fistula, or if there's CPR ongoing, you'll see the femoral vein pulsing slightly. Yeah, so just maintain a high degree of suspicion. If you put the cannula in, you get bright red blood back really quickly. Just be thinking, maybe that's actually the brachial artery, and just take a gas. Compare the SATs on the gas to the SATs on your pulse ox, and if they're the same, it's probably arterial. Remember, venous SATs, they should be around like 70, 80. It all depends on the amount of oxygen you're giving them and the amount of oxygen extraction that's going on, but it's not going to be the same as your SpO2. What happens if you put a needle into an artery? We'll talk about that later. But the main risk is if you put something down it that you shouldn't. Saline is fine, and we do that with art lines all the time. There's always a little bit of saline going into your artery to keep it patent. But things like thiopentone would be disastrous, and I'm sure you wouldn't put antibiotics down an artery. Right, Doppler. Just talk very briefly about Doppler. If you take one thing away from this slide, it's that color means nothing. So what is the Doppler effect? It is the change in frequency as something moves towards you or moves away. And we've all heard this before. When an ambulance comes towards you, passes you and goes past, it's and that's the change in the pitch because the frequency is changing as it's moving away. And the ultrasound probe can pick that up as well. And you can see here, there's blue and red, and that's flow towards the probe and flow away from the probe. But does this tell us if it's a vein or an artery? No, because it's all about the direction the probe is facing relative to the flow. Let's just imagine that I've got blood flowing down my artery like this, and I put the probe facing this way. It's going to look red. But if I tilt the probe now that way, now it's going to look blue. So the color tells you nothing. And if you're dead on 90 degrees to the flow, you get no color at all. How is it useful? Well, if you hold your hand really still and you put color mode on, you might see a pulsing artery. And if you're struggling to find some vessels and you put color mode on, then you see pulsing, well, that's probably an artery, right? You need to hold your hand really still because any movement, it shows up as color. And just be mindful that, you might get a mixture of colors. If there's turbulent flow, there's going to be some flow in one direction, some flow in the other. But pulsatility normally means artery. Some complications, we said putting things down the arteries, one of the risks, and also extravasation, which we'll talk about next. You could cause an arterial dissection or a spasm. Here we've got somebody's hand, which is, obviously they've not done Allen's test. Remember, Allen's is where you check for patent collateral ulnar artery before you stick something in the radial artery, and they've caused radial artery spasm, which has caused some pallor and ischemia in the hand, and it's slowly resolving, fortunately. You can also dissect an artery, and that's going to be a much bigger risk up here in the brachial artery where there is no collateral. The bigger the needle, the bigger the risk. Or you can cause a nerve injury. So remember, arteries run with nerves. here is somebody who's had a permanent radial nerve palsy, not from an ultrasound guided cannula. Actually, if you're cannulating the Houseman's vein near the anatomical snuff box, be mindful that the superficial branch of the radial nerve runs near there, and you can actually cause a nerve injury. So I don't go there anymore. And who needs to if you can do ultrasound? Right, extravasation, the main risk. Just be mindful that these are deep veins. The deeper the vein is, the more the cannula has to traverse the tissue. So there's less of that plastic in the vein. And so when they move their arm, it's more likely that plastic pops out the vein and your cannula tissues. That's not such a problem with your liter of plasma light, but if you're putting things down it which could be potentially caustic or irritant to the tissue, then that's going to be bad. So I don't put anything which is irritant or vasoactive down a ultrasound guided cannula unless I know it's definitely in a significant amount. So those are things like amiodarone, TPN. Remember, TPN is mostly 50% dextrose, calcium chloride, and NORAD. Just a side note, calcium gluconate is different to calcium chloride. Calcium gluconate has got 3 times less calcium in it, which is why you can give it peripherally, no problem. Whereas calcium chloride, unless it's an emergency, should go through a central vein. The treatment for hyperkalemia is 30 mils of gluconate, and it's 10 mils of chloride. And now there's prescriptions for low-dose peripheral NORAD. Check out the ICS if you want to read about that. So how do you do needling? Really, there's 2 different ways. Firstly, we'll talk about static, which is where you just put your probe down, you find a needle, you find a vessel, you put your probe there, and then you keep your probe there, static. And the idea is that if you know that the vessel is A centimeters deep, you come back A centimeters, you put your needle in 45 degrees, and hopefully your needle appears here, but you might damage the structures which are between here and here. So I recommend a dynamic technique, and we'll cover that in a minute. How do you choose your vessel and cannula? Well, we spoke about the risk from extravasation, and there was a study in the EMJ that looked at if you've got more than 60% of that plastic tube in the vein, then they don't tissue. Whereas if you've got less, under 30%, 100% tissued within 72 hours. So that tells us 2 things. Get a long cannula, and the green is longer than a blue. It's 4 centimeters. The blue is 2.5. Always go for at least a green. And there are actually longer than green. So you get these really long cannulas, which are designed for ultrasound guided cannulation. They're 6.4 centimeters, but they don't seem to exist in the NHS. And go for veins that aren't that deep. We're using some maths, you can tell yourself that 1.5 centimeters is the absolute maximum. And in my opinion, you shouldn't go for one that's more than a centimeter. So between a centimeter, 1.5 centimeters should be your absolute max. And it's got to be sufficiently wide for you to get a needle into. So speak about the 10-5 rule. 10 millimeters deep, 5 millimeters wide, straight, no clot. That's a goer. Remember, with your 4 centimeter cannula, you could get flashback in a vessel which is 4 centimeters deep. Give yourself a pat on the back, and then as soon as you turn around, it tissues. So there's no point. This is a bit of an advanced slide, but if you don't go in at 45 degrees and you go in a lot steeper and closer to the probe, you can waste less of that cannula in the tissue. And that's what I do now, but it's difficult because you need to tilt the probe. Here is what happens when you have a steep approach and you don't tilt your probe. So you can see here, most of the beam which is reflected is not coming back to the ultrasound probe, and that gives you a much duller image. Whereas if you tilt your probe so that your probe is always perpendicular to your needle, you get a much stronger image. So you can go in really steep, but you need to flatten your probe as you go in. And there are other ways to increase your image. You can turn off tissue harmonics and you can turn on spatial compounding, but that's more advanced. So dynamic approach, and this is where you move the probe as you move the needle. And the idea is that you always know where your needle tip is so that you know that you're not going to damage any structures on your way down to the vessel. There's really 2 ways that you can do this. There's in plane, which is where your needle and your probe, so that credit card thick beam that we spoke about and your needle, are in the same plane. And there's out of plane, where it's a sort of a cross section of your needle. This one is nicer, it looks nicer. You can see the whole needle the whole time, but it's much harder to align this. And if you don't have perfect alignment, if it's like this, you might be hitting a structure which is adjacent to your beam and that you're not seeing the beam and you don't see all of the needle. So if we're doing an IJ and it's in plane, imagine that your needle could just be poking out here and hitting the carotid and you have no idea. So don't use this technique, use the out of plane, otherwise known as the short axis. This is easier. It gives you a cross section of the needle. So all you see is a dot. But the risk from this technique is that you might mistake this dot and you see a dot and you, aha, I found it. And you might think that's my needle tip, but it might not be. It might just be the shaft instead of the needle tip. And so imagine that if you put your probe here, you'd see a dot. You put your probe here, you see a dot. So how do you know which one's the needle tip? Well, as soon as you find the dot, you move your probe distal along the needle until the dot disappears. That's where your needle tip is. So lastly, we talk about the vanishing target technique. This is how you advance your needle and track the needle tip all the time. Don't worry about the things that are written on this slide. You're going to see a video of it now, but a good explanation is imagine you put your probe down, you find your needle tip. Okay, it's here. Okay, I've lost my needle tip, come back. Okay, it's right here. What you're going to do, and this is what you're going to practice in the needling workshop, is get used to doing this to and fro technique, where you see the tip vanish and then reappear and vanish and then reappear. And that's how you walk it in incrementally. And so what you want to do is move the probe or the needle, not both at the same time. So I found my tip. Now I'm going to move my probe away until the dot disappears. And then I'm going to move my needle and hold my probe still until the needle reappears on the screen. Now I'm going to hold my needle still, and then I'm going to move my probe until the needle disappears, and then I'm going to move my needle until the needle reappears. And it's this to and froing that allows you to walk your needle tip, and you know where the needle tip is at all times, down into the tissue, into the vein, and then you can even walk the vein all the way, you can walk the needle all the way along the vein, which is what we're going to see now. So here we can see needle appearing, and you'll see it tent on the vein. And this is just some artifact, actually. The needle's not yet in the vein. Okay, now it's in the vein. And what you'll see my colleague doing is this sort of to and froing. It's not the best video, actually, because you never see the tip fully disappear. And as you get more practiced, you kind of do both at the same time. But as you're practicing, you want to do the vanishing target technique. And this is also great. This is my arm. And you can see here, this is my median nerve. And the nerve looks to me like a bundle of spaghetti when you measure it up. And that's what it is. It's a bunch of fascicles. And you can see the close proximity to my basilic vein and the median nerve. So you definitely don't want to be around here when you're practicing. Okay, and then how do we confirm that we're in the right space? So you've taken the needle out, you can go back with the ultrasound and you can look for the bullseye. You can see the plastic in the vein, or you could look in plane. You can see the cannula coming down through the tissue. You can try and aspirate, and if you can easily aspirate with the tourniquet on, you know that you're definitely in the vein. And if you can't with the tourniquet on, sorry, you're probably not in the vein. You might have been at some point, but you're not anymore. Similarly, you can put a flush down it, and if you go from this to this is what edema looks like. This is tissue in your fluid planes. That fluid has not gone into the vein, it's gone into the tissue. You're not in the right space. Lastly, you could look at the vein and inject your flush at the same time, and little pockets of air that are in the flush, your posi flush does contain a little bit of air. It's fine to put air in the vein, as long as it's less than, I think it's something like 3 mils per kilo is enough to cause a venous air embolism that might kill you. So, for me, that's something like 200 mils of air. Anyway, little buckets of air in your flush, and they're very echogenic. This is a bubble echo where they purposely inject air to see if it goes across a PFO, but you will see the air in the vein, and it's very obvious if your flush is going through the vein. You can also put your finger over the vein and you can feel it. All right, so let's summarize. We're going to watch a video now. This is a 5-minute video of me doing ultrasound cannulation. Don't worry about this equipment list. That's going to be on the ultrasound machine. So here we go. We have collected our equipment. Now we've got our machine. It's in place. I would probably move this machine over here. So this is poor ergonomics from me. What I want is the arm and the ultrasound machine all in one line. But I have made Sophie comfortable by putting some towels underneath her arm. And I'm just going to do a quick scout here in a non-sterile way, just to find a nice vein. I just tapped on the ultrasound there to check my orientation. Remember, you've got to tap on one side and check that it appears on the correct side. Right, so we've got depth on the right, and that is too deep. So I'm optimizing the image here, and you'll see suddenly it's going to look a lot different because I've changed the depth. I'm looking at this vein here and checking that it compresses and it's not pulsing. And so I found a nice vein. It satisfies my 10-5 rule, and that's a goer. And so now I am going to leave a mark. I think there's a nice video here about, yeah, so this is great. This is telling the difference between a vein and an artery. This is a different arm, but you can see here in this video that there's two vessels here, they're pulsing. One of them is blue and pulsing. Remember, color tells you nothing, but it is pulsing, so it's an artery. Whereas up here is non-pulsing and blue and compressible. And this one here is a mixture of colors because there's probably some turbulent flow. So which one are we going to put a needle in? That one. All right, so leaving a mark with the cap, cleaning, using the ChloraPrep. Local, I probably wouldn't use local now, unless you're doing a gray or an orange, then, or you like the person. So I use local here on Sophie. Other ways that you can make the local sting less, inject it slowly, warm it up, or use an insulin syringe, so even smaller than an orange needle. Here is how to make a DIY sterile probe cover with a sterile glove. You can watch the video on the academic life in emergency medicine, but essentially stretch the sterile glove over the probe when the probe is down. You need gel on it already. Pull it tight, get the air out, and wrap something around it. I've never touched this bit, and that remains sterile. Put more gel on. Right, so now let's watch some actual needling. This isn't the best video, you can't see the screen that well, but what it does show you is some key things. Ergonomics, I'm at the right height. I'm holding the probe nice and low down. I'm resting my hand here, nice and stable. And what you can see is how I find the needle. So remember that your screen, that vein is probably 5 millimeters deep. So on my screen, I might have 1.5 centimeters. You only need to put the needle in a few millimeters and then stop and then find your needle. And I find the best way of actually finding your needle is put the probe where you know the needle is. And I put my probe directly on top of that puncture site. And I'm looking at the top of the screen for a really bright dot because the needle is very echogenic. And then I'm finding it and I'm tracking down. And you're going to see me make really small movements and readjustments. And I'm going to move one thing at a time, either the probe or the needle. And then you're going to see the vanishing target technique as we move that bright dot closer and closer to the vein. Right, yep. So closer and closer, walking that needle down into the vein. Now the needle is inside the vein. We're going to do the vanishing tip technique, where to and froing, we can actually walk the whole needle down. And that's what I've done there. There's no flashback and then advance the plastic. The whole needle has gone in and then you take the needle out. Ultrasound gel makes your tegaderm stick very poorly. So you need to dry the whole area very, very thoroughly. And then we'll show some confirmation. There's the bullseye sign, and we're going to flip it to in plane, and you can see the plastic cannula coming down from up here down into the vein. Lovely. All right, so that is a summary of what it's going to look like. So now you have it. You have everything you need. You can go away and practice. You can make DIY phantoms. In my opinion, the best one is gelatin. You can buy the powdered gelatin and have a look on YouTube. You'll see how to make it. You need some sort of lumen. Par-cooked pasta is quite good because you can pierce it. Apparently tofu and corned beef work quite well. I used chicken breast once. strongly recommend not doing that because it is an infection control nightmare. Derwent Valley, we've got these expensive phantoms. You can email or call and book to come and practice on them. They're quite expensive and you can do some things to ruin them. So just check with the technicians how to use them properly. And then you'll move on to practice. So the idea from this course is you watch this course, you come to the procedure workshop, and then we'll give you a logbook, and then you need to do 10 supervised scans. So 5 with us watching you, and then 5 unsupervised, but you show us your images. The best people that you can get to supervise you, we're going to arrange some days where you can come up into theatre, but you can also ask the on-call anaesthetic SHO, probably during the day or at night. You know, if you're going to call up and ask somebody to come and do a cannula, if you can say, I've watched a video on how to do this, I've got all the equipment ready, can you come and supervise me? I'm sure they'll be willing. Okay, here's the post-course knowledge check. Pause and try and answer these questions. Here's some videos of some of the workshops we've done in the past. And here is a recommended structure for the workshop for anyone that wants to run their own course, some tips and some timings. Thanks very much for listening. I hope that was helpful. I hope we've done it in 30 minutes. If you found that helpful, please let me know. If you've got any feedback, also let me know because I genuinely listen to it. All right, cheers, all the best. Good luck. Bye.